Hi, this is Brian Kim. I'm going to share with you case number 38 in the best way to do cataract surgery series. This is a mild to moderately dense lens, and you can see double chop, cross chop, mechanical fracturing. And at the end, you're going to see that there's quite a bit of subincisional cortex. You're going to see the use of the cortical flush technique using a BSS cannula to liberate the subincisional cortex. I'm using a cotton tip to help center the eye, and then I'm using a corneal marker to help me center and size my rhexis. I use the cotton tip now to turn the eye so I can have a flat approach for my paracentesis incision superiorly and inferiorly. I'll make a paracentesis incision parallel to the iris plane for a self-sealing corneal incision. I'm injecting some intracameral lidocaine very slowly, and then I'm injecting some dispersive viscoelastic to inflate the anterior chamber and coat the corneal endothelium. And this is my triplanar corneal incision. I'm turning the eye with the cannula away from me. I make a vertical groove, place the blade into the deep part of the groove, tunnel through the cornea, use the cannula, turn the eye toward me, and then I dive in, and that's the triplanar corneal incision. This is my puncture style Capsulorhexis. I'm going to puncture centrally with the forceps, and then I'm pulling downward towards me, and I'm grabbing the cut edge on the right side to create a flap. And once I create that flap, I'm going around and then grabbing again. I'm grabbing fairly close to the flap, and going every 1 to 2 clock hours just allows you to have better control. And I'm trying to use the corneal mark to help me center and size the rhexis. I finish the rhexis and I burp some viscoelastic out of the eye. And this is the Capsulorhexis hydrodissection technique. I place the cannula out underneath the anterior capsule rim on the contralateral side. I point the tip down and you get a nice fluid wave. I decompress on the left side. I'm sweeping on the left side. I turn the cannula towards the right side now, point it down and peripherally, and then I use the cannula to help me spin the lens. I lift my incision with the chopper and I go in with irrigation off to minimize decimase trauma. I remove the surface epinuclear material in the center, and then in the pronated position, I slide the chopper underneath the epinuclear ridge out to the equator. I place the phaco tip vertically, subincisionally, and I'm able to crush the density of that lens in half. This is the double chop maneuver. I place the chopper out to the contralateral equator and crush the lens on the right side. I use high vacuum to prolapse that first quadrant up, place the chopper around the lens, and then crush it against the phaco tip. And then I'm using mechanical fracturing forces to crush the lens into smaller bite-sized pieces and then emulsify the lens pieces. I'm using vacuum to help me hold the eye, lift it up a little bit, and then use the chopper to get around the lens and then crush it into smaller pieces. Place the chopper out to the equator again, and then I'm pulling that lens piece up. I crush the lens piece between the chopper and the phaco tip. I'm crushing the lens pieces into smaller pieces and emulsifying the lens pieces. Again, I'm using vacuum to grab the lens pieces, crushing it with the chopper, and then emulsifying it. I'm going to turn the lens with the chopper. It's not really moving that easily, and in order to reduce trauma to the zonules, I just use a little vacuum to help me turn the eye with the phaco tip. I place the chopper out to the equator, place the phaco tip deep, and then crush the lens piece by pulling the chopper centrally toward the phaco tip. I do the same maneuver around that third quadrant, and I pull the chopper centrally against the phaco tip, and I'm able to crush the lens piece. Take the remainder of that third quadrant using high vacuum to pull it up out of the bag, and then crushing it with the chopper against the phaco tip, and then using mechanical fracturing forces, crushing the pieces into smaller bite-sized pieces, and using high vacuum and a little bit of burst of ultrasonic energy. This is the last quadrant, placing the chopper out to the equator, and then using a little bit of vacuum to pull the lens piece up, and then crushing the lens piece between the chopper and the phaco tip. Maneuvering the lens piece in such a way that the chopper and the phaco tip can crush the girth of the lens. Place the chopper around the lens material again, and then crushing it against the phaco tip. Using vacuum to hold the lens piece, and then crushing it with the chopper, and then using mechanical fracturing forces to crush it into smaller pieces, and then emulsifying it with high vacuum and some ultrasonic energy. Removing the epinuclear material, which comes out quite easily here. I always keep the chopper deep to the phaco tip to reduce the risk of posterior capsule rupture. I take the chopper out. I push BSS with a cannula through the paracentesis, pull the phaco tip out, and then place the INA handpiece. This helps minimize the chamber pressure fluctuation. I remove the cortical material, sweeping side to side. You can see I have quite a bit of subincisional cortex despite my best effort. I switch to the polish mode, and I'm polishing the anterior capsular rim of any cortical material and lens epithelial cells. I'm just taking my time, making sure the anterior capsular rim is nice and clean. Going into the capsular fornix, making sure I'm not missing any small bits of cortical material. I'm trying to loosen up the cortical material in the subincisional space, and then I'm using a cannula to pulse the subincisional cortex. This is the cortical flush technique. I'm placing that cannula into that subincisional fornix area, which now liberates that cortical material. I'm able to grab it with the INA. I switch to cortex mode to help increase vacuum, and I'm able to remove those lens pieces. I go back with the cannula, and you can see there was a little bit of cortical material that was liberated with that maneuver. I switch to the cohesive viscoelastic cannula, and then I'm going to go with the capsule sweep. I'm going to sweep the left side first, and sweeping underneath the anterior capsule rim to remove any potential lens epithelial cells. I do the same thing on the right side now. And with this maneuver, you want to apply just enough friction so that it causes the removal of the lens epithelial cells, but it still needs to be in the horizontal direction. A little bit of upward movement, but not too much that you traumatize the iris. I use the sweep to hold the eye, and then I inject the single piece acrylic lens into the capsular bag. And then I use the INA handpiece to help disengage the haptics from the optic. And then I go under the lens and rotate it clockwise 90 degrees. I tilt the lens as I remove the viscoelastic from within the bag. Once I remove the viscoelastic from within the bag, I'll try to turn the lens another 90 degrees to make the haptics in a more horizontal position to see if this will help any potential dysphotopsia issues by placing the haptics in the horizontal meridian. There's some cortical material just underneath the anterior capsule edge on the left side here, and I'm just really taking my time to just tease that stuff out. It's a little bit stubborn here. I'm just using gentle vacuum. And then I decide to just put the lens optic over the capsule and then use high vacuum, see if I can get it. And I was able to remove that little bit of cortex now. I switched to the viscoelastic mode, and I'm able to remove the viscoelastic from the anterior chamber with high vacuum. Pushing BSS into the angle to remove any potential viscoelastic material. and then I quickly hydrate my incisions, and that's the end of the case. And so this was, again, a mild to moderately dense lens. You can see I used double chop, cross chop mechanical fracturing forces to disassemble and crush the lens into smaller pieces using mechanical fracturing forces. And this helps minimize ultrasonic energy use, and this helps keep the eye in a very controlled situation. There was some cortical material in the subincisional space. Yes, you can go to bimanual, but I like to use a cannula while I'm irrigating the eye with continuous irrigation with the INA handpiece. I'm able to flush quite a bit into the subincisional space. This liberates that cortical material very easily. So I hope this was helpful to you, and I thank you for your attention.